Hello, everyone. So, we are now on the second part of this thyroid function based discussion. And I have chosen the most important thing is subclinical hypothyroidism. When the patient is clinically euthyroid, but there is a deficiency in the thyroid gland, like a tip of the iceberg. Very few of the cases were tested for TSH. Sometimes we found an elevated TSH and rest euthyroid clinically, and the T3 T4s are normal. We call it a subclinical hypothyroidism. So what is a subclinical hypothyroidism? Let's see. When serum TSH level above upper limit of normal, despite of normal level of FT4 for a given reference population. And what is overt hypothyroidism? When serum TSH level is above normal and FT4 is less than normal. So subclinical hypothyroidism usually clinically behaves like a euthyroid or normal patient, but with a definite deficiency of thyroid function. Now, if we go for that, subclinical hypothyroid key features, incidence ranges between 4 to 20% of cases of population where females more than males, particularly very high with a low iodine intake, high age, increased age, or somebody who has a positive family history. Variables like age, gender, lack of consciousness, these are things are making things even more difficult because a regular basis checking is sometimes not possible. National Academy of Clinical Biochemistry (NSCB) has suggested that normal TSH range should be between 0.4 to 2.5 rather than a conventional 0.4 to 4.5 milli equivalent per liter. So that is a suggestion, but I think now even with 4.5, the features of subclinical hypothyroidism are often overtreated also. Now, what are the risk factors? Risk factors of subclinical hypothyroidism are presence of autothyroid antibodies, sometimes a history of radiation around head, neck, or chest, sometimes other autoimmune diseases are associated, particularly when a patient is going in old age, excess iodine consumption, that is also very difficult. In excess iodine can lead to iodine constipation, and that can hamper the thyroid formations also. Again, the doses like lithium or amiodarone, other thyroid diseases, and particularly subclinical hypothyroidism runs in families like type 2 diabetes mellitus. So there is an importance of family history as well. Subclinical hypothyroidism is more than 90% are usually between 4 to 10. Approximately 65% normalize within 5 years without intervention. That means subclinical hypothyroidism, most of the cases, is a transient phenomena. Level subject to biological variation, so therefore also subject to the transient rise in stress and illness. So therefore, we have to consider all the factors before you diagnose a patient to be hypothyroid and treat them. This is what a person in a euthyroid state, you may find a TSH within normal range, T4 within normal range. Now what happens when the persons are functioning of thyroid gland is decreasing? In such conditions, when functions are decreasing, what I told already in the previous class, that there is a negative feedback goes on and the negative feedback reduces. So that means the hypothalamus as well as pituitary signal senses the signal that there is a deficiency in thyroid gland. You have to overcome by more and more secreting TSH. So what happens? TSH increases its secretion above normal range. So because of excess push or excess effort of TSH, T4 still remains within normal range, and the patient's clinical scenario, since the clinical scenario does not depend on TSH, clinical scenario depends on the T4 and T3, and hence the FT4 or T4 remains in the normal range. Patient behaves like a normal, and that is a compensatory phenomenon. That is, it is compensated by high secretion of TSH. The patient is becoming euthyroid. So this condition is called subclinical hypothyroidism. With time, again, the thyroid loses its capacity to release more and more T4. Therefore, TSH goes on more and more to give more and more push to the thyroid gland. But if despite of that, they cannot produce adequate T4, then this condition is called overt hypothyroidism with a high level of TSH and less than normal level of T4 or FT4. What are symptoms? There may be some of the symptoms, not always. Subclinical hypothyroidism usually comes with a cold sensitivity, sometimes dry skin, a hoarseness of voice, constipation, poor and sluggish thinking, anxiety and depression, and sometimes most commonly fatigue and muscle cramps. May just reminded that there may be no symptoms also. In of the cases of subclinical hypothyroidism, you may not find any symptom at all. The patient may behave just like a normal with a high TSH level. So, necessary to detect nevertheless is risk to progression to overt hypothyroidism. Usually in a year, a subclinical hypothyroid converts to hypothyroid by 2 to 5% of the cases. And if there is a presence of anti-TPO antibody, then the risk of developing overt thyroid or hypothyroidism in long run is even more. The major things which is to be assuring is that sometimes it is self-resolving, so no intervention required. Symptoms are mild and non-specific and asymptomatic. Sometimes, again, I am saying most of the cases are asymptomatic. Possible complications, what can happen if it is remaining untreated? There may be some overt hypothyroidism and thyroid failure, metabolic syndrome like dyslipidemia, hypertension may come along, neuromuscular complications, and also ischemic heart disease and cardiomyopathies can come with overt hypothyroidism of a long standing. The diagnostic modalities. CH is categorized in two groups. One is a mild variety, which is TSH remains between 4 to 9.9, and a severe variety when TSH is more than 10. Why I am calling severe variety? Because TSH is more than 10.10, more than 10, but T4 and FT4 are normal. That means thyroid is giving so much stress and extra effort by TSH to keep it in normal. That is why. So, once you get a TSH high, don't see and don't stamp the patient as hypothyroid immediately. If it is a mildly raised TSH, observe and do a test after 1.5 months or 6 weeks. And if still the same trend is continuing, then you can stamp this patient as a hypothyroid. Now, treat or don't treat, I have a huge discussion later on. Anti-thyroid peroxidase or anti-TPO antibodies, if present, then your diagnosis becomes more confirmed toward hypothyroidism. Sometimes you may need to do a USG of neck. And the last is 99 technetium scan or thyroid scan, maybe with radioactive iodine, 99 technetium also, to detect the exact condition whether thyroid nodules are active or inactive. The management study, how to manage this. So management from the variceum category, as I said, if it is more than TSH is more than 10, start levothyroxine. Fine. And it is seen that early stage treatment has also protected against our dyslipidemia. That means cholesterol is rising in hypothyroidism, very common feature. So if you early treatment reduces the risk of cholesterol level, rise of cholesterol level. Sometimes it is beneficial in neuromuscular, psychiatric as well as cognitive disturbances as well. Special considerations. When a treatment of TSH, when TSH is between 4.5 to 10, in those conditions, whether you treat or don't treat, sometimes you may treat. What are the special conditions where you actually treat even when the TSH is less than 10? Particularly in children and adolescents, you just can't afford to be hypothyroid in this condition. Even the person becomes hyperthyroid, we open treatment still okay, but can't afford to be an hypothyroid. Goiter, patient with goiter, definitely. So, but there is a more than 5, but on 2 occasions, we have found that TSH stepwise increasing. In such condition, the trend shows that the patient is definitely hypothyroid and going more towards overt hypothyroidism. Sometimes there is a bipolar disorder or depression, ovulatory dysfunction and infertility. There sometimes hypothyroidism itself can be a contributor to infertility. So if you find a high TSH in those conditions, despite of the condition, should start treatment. Pregnancy or desire has to be pregnant. That is very important, as you say that a neonatal development of brain and body organs are very, very much thyroid dependent. So therefore, you have to be very cautious if the patient is pregnant or even wants to be pregnant. You should be treating that patient. The question is here, to treat or not to treat. So now you see, when you have an elevated TSH, confirm, check for free T4, anti-TPO and lipids. Now if TSH is less than 10, then you check, depend on TPO. If anti-TPO is positive, consider treatment with levothyroxine. If anti-TPO is negative, then see whether the patient is symptomatic or goiter or young or pregnant or having a dyslipidemia. If any of the conditions are there, then go for a treatment. If not, just go for a follow-up. Now, if it is TSH more than 10, treat with levothyroxine straight away. Don't hesitate. Now, there are certain conditions which is called Sick Euthyroid Syndrome or Sick non-thyroidal illness. Subclinical hypothyroidism in non-thyroidal illness. So what happens when sometimes a patient is suffering from a chronic illness, presenting in ICU for a long time or a chronic illness? What happens? The thyroid hormone production that decreases grossly, and that is actually instead of T3, reverse T3 production starts. So what happens in this case? And reverse T3 production starts. So the RT3, as you know, is metabolically inactive. This is what happens. This is a condition during the phase of the initial phase. The TSH is normal. FT4 and T4 both are normal. But with a chronic illness, the FT4 and T4 decreases its function. So now when this is the condition where reverse T3 is secreted maximum and T3 is secreted at the minimum. There are some conditions, unfortunately, if you take the patient during the time of recovery, this is the patient of recovering phase from a chronic illness. During the phase of recovery, if you draw blood of this patient, you will find there is a slightly rise of TSH above normal range and low normal FT4, low T4 and low T3. This is a classical symptom where T3, T4 low, TSH high, FT4 low. So you have to diagnose this as a hypothyroidism or subclinical hypothyroidism. But I'm reminded, this patient is not at all hypothyroid. This is after a chronic illness, patient is recovering, and during the phase of recovery, TSH shows more than normal range of it, and T4, T3 all are low because the production was dropped down during the illness. So this condition, if somebody found, then the patient will be treated for Sick Euthyroid Syndrome, will be treated as a hypothyroid, which is very detrimental in this condition. So therefore, never treat a patient with a chronic illness suddenly found to be a hypothyroid. This is a condition called Sick Euthyroid Syndrome. You should be very aware of this kind of condition. Now, subclinical hypothyroidism pregnancy, you cannot take chance. So therefore, TSH level should be checked till the first trimester and treatment to be offered even a planning to conceive. Not even the patient is we are not pregnant or not, even a planning to conceive, you should treat. And also, because adequate replacement with levothyroxine sometimes prevents to develop preterm labor and also prevents development of spontaneous abortion, pregnancy-induced hypertension, gestational diabetes mellitus, and also reduce key IQ of the offspring because the brain development is a major function of thyroid hormones. Now, this is the very typical picture I am producing to you, that all the four features are almost similar. A 78-year male, occasional tiredness with memory loss. 25, 4 years female, hair loss, just married. 45-year muscle cramp, hypertension, diabetes mellitus, smoker. 35 years male, critical care unit with sepsis. These all are actually giving a feature or similar type. TSH 6.8, FT4 14, that means normal. Thyroid peroxidase antibody just above cutoff range, that means positive. So all that four having the same thing. Same TSH, same FT4, same anti-TPO. Which one you will treat and which one you will not treat? So, my call, 78 years male, occasional tiredness and memory loss is an age-related symptom. I don't think it's a thyroid-related symptom. I will not treat this patient. 45 years male, hypertension, diabetes mellitus, immediately no need to start treatment. You can check with the second effect and then treat. And this is typical of Sick Euthyroid Syndrome. A patient was suffering in a critical care unit of sepsis, thus recovering, so you may get this. But this particular patient, I will start treatment. Why? Because not only hair loss is a non-specific symptom, not for the thyroid, but for this factor that the patient is just married, because she's just married, maybe planning for a pregnancy. I can't afford to keep her hypothyroid at any cost. So only one treat out of these 4 patients I'll treat is that those who are 24 years female with hair loss and just married. The guidelines are now, there are several guidelines which is changing one after another. But the recent guideline is when TSH is less than 7, age 65 to 70 years, don't treat, just observe. Age 65 to 70 years, treat if symptoms. Without symptoms, just observe. TSH between 7 to 10, again age more than 65 years, no treatment. Observe with symptoms. If symptoms, then treat. And if TSH more than 10, treat the patient. So now a guideline is straightway start treatment if TSH is 10. If TSH is less than 7, observe. If needed, if gross symptoms are there, treat only. So now, medicine routine, very important. For levothyroxine, treatment regular is very important. And at least 2 to 3 months visit and testing of TSH and FT4 is mandatory when a patient is under treatment. Now, adverse effects, sometimes you can give an overdose, which can lead to a hyperthyroidism state because of an overdose. Or sometimes it is maybe the patient is hypothyroid because you are not treating. So there are both the areas, there are problems. You have to deal with problems according to your clinical justification. And one more thing, levothyroxine should always be advised to be taken in empty stomach because absorption of levothyroxine or a T4, it largely depends on a free stomach. Food hampers its absorption very gross. So, emotional well-being. There are 2 sides. A patient of getting treatment, although may not be required, can also create tension. And also not getting treatment, getting treatment may not be required, also in raise tension. But cost of treatment is less than the cost without doing treatment and producing a overt hypothyroidism. And as I said, food habit, always take it in empty stomach, the medicine, then start taking your meal. Now, therefore, this is an nutshell summary and recommendation. So, elevated level with thyroid hormone and a normal free T level, it depends when you treat or when you not. When patients with no symptoms, diagnosed after screening, or patients with non-specific symptoms, don't treat, just observe. May not apply when patients with severe symptoms and young adults less than 30 years because for them, development of muscle, brain are quite a bit dependent on thyroid, so you may consider treating. Now, when the patient is a pregnant one or becoming pregnant, and the patient with the TSH above 20, there is no question of Observation, treat the patient straight away. So this is a nutshell about subclinical hypothyroidism. I have taken out this particular topic among all because this is the common thing. The hypothyroidism is the commonest one we encounter in our day-to-day life, and subclinical hypothyroidism is even commoner. So, as a patient, you also should know if you start treatment or not. As a clinician, also you should know whether you recommend for it or not. So that's all about it, thyroid. Thank you. We'll be coming very, very soon with another topic. Thank you.